Heavenly Father, at this time of pandemic, we pray for all those who have suffered. With tired and heavy hearts, we lift our spirits to you, O Lord. Protect us and be with us, especially those of us most vulnerable. Please watch over our health workers and help them stay strong. May they find the strength to continue serving your people. O Lord, may you give comfort to the families of victims who have passed. Move us to reach out in love to those who need. Allow us to see hope in the new world we face today. Help us rebuild it together, founded in your compassion and promise. In your mercy, hear our prayer. Amen.
Ladies and gentlemen, the President of the Philippine Society of Pediatric Surgeons, Dr. Santiago Aquino.
Welcome to the third series of June Resurrections webinar. For the previous webinars, we discussed about the challenges of pediatric surgery in the COVID-19 pandemic, as well as stem cell therapy in pediatrics, particularly in neurology, more specifically in the treatment of cerebral palsy. Now, our topic will deal with social medicine in healthcare, telemedicine, and its medico-legal implications. Our distinguished guests for today are Dr. Dominique Vervoort, Dr. Isip-Tan, Dr. and Attorney Albert Rebosa. It is my privilege and pleasure, on behalf of the Philippine Society of Pediatric Surgeons, to have you with us and to participate in this event. To the organizing committee, thank you once again. And to all participants in this webinar, I do hope that this event will enlighten us for our future medical practice. Thank you and good day.
To introduce our speakers for today, here is Dr. Edric Lim.
Good morning. Welcome to the third PSPS webinar. We have three speakers this morning. Our first speaker is Dr. Dominique Vervoort. He finished his medicine at KU Leuven, Belgium. Had a Paul Farmer Global Surgery Fellowship at Harvard Medical School in 2019. He was a research assistant at Leuven University Hospital, COMFO, a Nokia Teaching Hospital at Leuven Institute for Healthcare Policy, and Harvard Program in Global Surgery. Currently, he is taking up Masters of Business Administration, Healthcare Management, Johns Hopkins Carey Business School, and also Masters of Public Health at Johns Hopkins Bloomberg School of Public Health. Our second speaker is Dr. Thiele Isip-Tan. He graduated medicine at UP College of Medicine, Manila, had his residency in internal medicine at UP-PGH and fellowship in endocrinology at UP-PGH. She was awarded Ramon Abarquez Outstanding Research Fellow and is taking up Masters in Health Informatics UP Manila. She was also awarded as the first UP System Gawad Pangulo awardee for progressive teaching and learning in 2015. She is presently Professor, UP College of Medicine, and Director, UP Manila Interactive Learning Center. Currently, she is taking up her PhD in Health Sciences, UP Manila. Our third speaker is Dr. Albert Dario Rebosa. He finished his medicine at UST Medicine of Faculty of Medicine and Surgery and graduated law, San Beda College of Law. He is one of the authors of the Basics of Philippine Medical Jurisprudence and Ethics, 2010 edition, and the Philippine Medical Jurisprudence, Platinum First Edition. He is a medical legal consultant to numerous medical centers in Metro Manila and is a partner, Castro, Rebosa, and Rebosa Law Office. He is an assistant professor, legal and forensics medicine at DLSU College of Medicine, St. Luke's College of Medicine, and Our Lady of Fatima College of Medicine. To moderate this webinar is Dr. Dures Tagayuna. He finished his medicine at UST Faculty of Medicine and Surgery, had her residency in general surgery at St. Martin de Porres, and fellowship in pediatric surgery at Philippine Children's Medical Center. She finished Master's Health and Hospital Management, Xavier University. She is the Chair, Department of Surgery, Jose P. Rizal, School of Medicine, Xavier University. Professor in Jose P. Rizal School of Medicine, Xavier University. She is the President, St. Francis Doctors Hospital, and is a council member of the Philippine Society of Pediatric Surgeons, and the current National Treasurer of the Philippine Medical Association. Here are some reminders. Please type your questions in the Q&A box. Indicate to which speaker you are directing your question to. You may also raise your hand and you can ask your questions live. Please be ready with your questions to facilitate faster transition. And make sure you do not accidentally press the raise hand icon. Thank you.
Let us welcome our first speaker, Dr. Dominique Vervoort.
Great, good morning, everyone, and kind regards from Belgium. My name is Dominique Vervoort. I'm a doctor from Belgium and a current MPH MBA dual degree student at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins Carey Business School. And I'm looking forward to talking to you all during this important webinar series about the topic of social media with a focus on public health, education, and global health advocacy during the COVID-19 era. I have nothing to disclose. I am going to talk about certain social media platforms and in particular about Twitter. However, I will not be talking about how to get started with Twitter, how to kind of advance your Twitter skills, but I will be talking about how to use social media, why to use social media effectively during COVID-19, but also beyond that for maximal efficiency. So we live in a time where there is widespread connectivity. Internet is reaching all corners of the world, and nearly half of the world's adult population has a smartphone today, and nearly 3 billion people have a social media account one way or another. The far majority of these people are on Facebook with over 2 million accounts. However, other platforms like, for example, Twitter have over 300 million users also registered on their networks, as well as other places like, for example, Instagram, LinkedIn, etc., etc. So the benefits of social media is that it is asynchronous, it is universal, it is instant, and it is participatory. It is asynchronous because it doesn't matter when we're sending out a message, for example, a tweet, people can still read it hours after. It is universal in the sense that you are sitting in the Philippines, I am sitting in Belgium, some of my colleagues are sitting in the US, and whenever we send something, it can be read by anybody around the world and can be read instantly by anybody anywhere in the world. And then fourth, it is that it is participatory, and that means that there are fewer thresholds in engaging and discussing through social media as opposed to in real life, where, for example, we're at a conference and we might feel held back to ask a question during a Q&A round at a conference, or we might feel held back to talk to a certain expert in the field because we feel that we don't have a certain expertise about a topic. And that's really bridged, or that's really bypassed on social media, where these thresholds are less vivid as they are in real life. So social media really is there to inform, to persuade, and eventually catalyze action and move people to action, regardless of what their goal is. And because of that, social media can really be closely linked with social change ever since the early years of social media. The Arab Spring and Japan Tsunami Relief Fund were great examples of getting hundreds and thousands of people on the same page, working towards the same goal through the use of social media in a very short time span. And also this year in 2020, we're seeing that with COVID-19, with the pandemic, that we're using social media for a variety of reasons, mostly for the better, really trying to enact social change, really to ensure that people are on the same page, talking about the same measures and having the same unified message, in order to ensure that whatever we're doing, specifically in terms of public health campaigns, that we're reaching a maximal efficiency. So social media has been recognized very early on during this pandemic, during the COVID-19 pandemic, for a variety of reasons. It can be used for public health education and countering misinformation. I'll be talking a bit more about those two things in just a second. In addition, can be used for telehealth diagnostics and referral systems, really to ensure that people aren't overwhelming the health system by, for example, presenting with certain symptoms, but not being sure that they have COVID. And so they might be able to rely on telehealth initially to get a sense of whether they should actually be screened, whether they actually should be presenting at the emergency department, at the GPs, etc., versus holding off and waiting at home to ensure that health workers aren't overburdened. Thirdly, is that social networks, and that's really what the core of social media was at the start, are there for social networks and social support systems through a virtual manner. And we live in a time where we're constantly reminded to socially distance, really keeping our distance from one another. However, this is really talking about physically distancing. And so the social aspect cannot be neglected, and the psychological first aid that can be brought by social networks, by social media, is definitely not something to disregard. Fourth, and that's also obviously what we're doing right now, is virtual learning. It's really a big shift from in-person meetings, in-person conferences, to virtual meetings and virtual conferences, and really been expanded as we go along and learn from these experiences. And in fifth, definitely not unimportant, is that research is being accelerated because we need to know what's going on with regards to COVID, how we have to treat it, how we have to diagnose it, how we have to manage it, on every layer of the health system and beyond that. And obviously, all this information needs to be disseminated to the people who need to know and need to implement these changes or this knowledge. And so with that, social media plays a big role as well. However, as I mentioned, I'm going to talk mostly about COVID-19 with a focus on public health education. And with that, I want to draw your attention to a couple of papers that recently come out. However, the experience definitely reaches far beyond just publications. But with the fact that social media not always has the best reputation in terms of actually catalyzing change, and sometimes even being counterproductive. However, in a variety of settings, on the left in the Netherlands, on the right in Jordan, even though it was self-reported, is that social media, through news media, through social influencers, through other variety of individual and institutional social media accounts, has been found effective in actually catalyzing change in terms of health behaviors. So to ensure that people are washing their hands, they're wearing their masks, they're socially or physically distancing, etc., etc. However, with the use of social media and with the fact that people can use social media whoever they are, whenever they want, and whatever they want to say, is obviously the risk of misinformation, conspiracy theories, and more. And that's unfortunately the flip side of social media and of the COVID-19 infodemic, as we can call it, because every day millions and millions and millions of messages pertaining to COVID-19 are being shared on social media. Early in the pandemic, the hashtags COVID, COVID-19, and coronavirus together combined had over 100 million tweets a day, which is a vast amount of information and can really overwhelm us at any point in time. So with that, it's not surprising that Dr. Tedros, who's the Director General of the World Health Organization, says that we're not just fighting a pandemic, we're also fighting an infodemic. And that is something that is important to remember with the use of social media and any kind of communication channel. With this comes the risk of misinformation through this infodemic, through this vast amount of information where everybody can really share whatever they want, whether or not they actually believe it or whether or not they can actually back that up with evidence. As a result, misinformation is definitely not harmless because there's a lot of groups who have purported self-diagnostic measures, such as, for example, holding your breath for a certain amount of time to see whether or not you have COVID. And that brings with it the risk that if people do this test and they feel, oh, actually do not have COVID, maybe they go out and do not adhere to the measures that they need to be adhering, like, for example, wearing masks, because they might, for example, be asymptomatic and then are still able to transmit COVID-19, despite the fact that they supposedly do not have the test because of the self-diagnostic measure. Secondly, is conspiracy theories ranging all the way from state leaders that are supposedly being dethroned by this fake pandemic, all the way ranging to COVID-19 supposedly being a cover-up for the harmful effects of 5G, all of which have obviously been debunked by scientific evidence, and all of which obviously are not linked to COVID-19. And so that's also a second risk of the misinformation spread through social media. Third is that some public health measures have been quote unquote debunked, or at least people have been trying to, like, for example, wearing masks, supposedly that would not have an effect, or that lockdowns or physically distancing wouldn't have any effects, because it plays against some people's agendas, it plays against some people's interests, or it plays against some people's willingness to adhere public health measures. And in some countries even, not public health measures, but plays against people's individual behaviors and preferences. And in some countries also has been politicized as a result of that, which is very, very unfortunate. Fourth is that people who have some experience with data analysis, with modeling, etc., might portray themselves as being experts of actually modeling how the pandemic will go or how an epidemic will go in a certain country and on a local region, and based on that trying to sway an argument one way or another, which we can call armchair epidemiologists because they're not trained epidemiologists, let alone in infectious diseases, and therefore something to watch out for. And then last and definitely not least, and I think we've seen this quite a lot the past few weeks and months all around the world, with certain treatments being portrayed as being the lifesaver for COVID-19, even though the evidence has not been there, or in some cases actually speaking against it. So when we're living in a time where we actually need unity, we're seeing a great divide within countries, between countries, all around the world. And that's obviously a major risk with the use of social media. It's therefore no surprise that here and there, more and more reports are coming up how misinformation, the spread of misinformation related to COVID-19 can actually cost lives, because people contract COVID-19, because people take very risky measures of not contracting COVID-19, and therefore, for example, eat soap and other kinds of behaviors that were told to them or were misinformed to them of supposedly preventing them from contracting COVID-19. And that's very unfortunate and a very risky time in history as well, and something that we have to be cautious about when actually utilizing social media to disseminate info. The second part of my presentation will also be about children's surgery, obviously, given the focus of the society as well, and with a particular focus on global health advocacy. Even though we live in a pandemic, and even though children might be less affected than adults with COVID-19, we cannot disregard the fact that children still suffer from other kinds of conditions as well, such as, for example, cervical diseases, which cannot be disregarded or neglected throughout this pandemic. And for this, I really want to zone down on one specific platform, being Twitter, as a social media platform that has a lot of benefits in terms of global health advocacy. Social media has a widespread involvement through high-level meetings, like, for example, the World Health Assembly, like the United Nations General Assembly, which is coming up next month, end of September. And it is a time where policymakers, funders, politicians, media channels, etc., are active in social media, and in particular, especially active on Twitter. With that, we can really use social media to make sure that we're reaching the people that we want to reach, like, for example, policymakers to enact change, funders to rethink what they're investing in, or actually thinking about situations like, for example, children's surgery in low and middle income countries, to actually invest in these services which they have previously disregarded. So social media can be used to disseminate our information, to communicate with individuals, and to also network and connect with like-minded individuals. And the power of social media, and specifically Twitter, then, has been previously illustrated at high-level meetings as well. This is, for example, Richard Horton, who is a Lancet editor-in-chief, and spoke to all the WHO member states, all the 194 ministers of health thereof, at the World Health Assembly last year in 2019. And before he went to speak to them, he asked his following on Twitter what they considered as a priority, as a public and global health priority for people and ministers to actually consider. He listened to his followers. He brought 5 major points when he spoke to all the member states at the World Health Assembly, one of which also was investing in safe surgery and anesthesia care, which has been a very critical component increasingly of universal health coverage, but is nevertheless not yet addressed or recognized to the same extent on the national level as well. So because of that, these situations are actually very big wins. And even smaller tweets, individual tweets, like, for example, these by the WHO and the UN, are very important because people generally do not recognize or do not relate institutions like the WHO and like the UN with surgery. They typically think of them being there for primary health care, maternal and child health, etc., but not necessarily for specialty services like surgery. And this is very important because this allows people to be primed. This ensures that people start to rethink about what the role of surgery within global health is. Because all around the world, 5 billion people do not have access to safe, timely, and affordable surgical care, of which almost 2 billion children and adolescents. And therefore, it is very important to recognize this issue on the global health agenda. This is to illustrate how social media actually reaches people. This was before I went to South Africa in January of this year to speak at the Global Initiative for Children's Surgery World Meeting, which happens every 2 years. And I spoke also about the role of social media. And I especially want to draw your attention to the fact that just this single tweet of me telling that I was going to present on this and going to this meeting reached nearly 6,000 set of eyes, so nearly 6,000 impressions, so the times that people actually saw this pop up on their screen. And also had over 400 people actually clicking, liking, retweeting, commenting on this. And this is very beneficial because people who hear about, for example, the organization, or in this case, if you're tweeting about the Philippine Society, that they hear about the society or hear about the issue of global pediatric surgery, hear about the issue of using social media for public health education, is that they will be more primed to be exposed to it or to recognize it or even to find more information regarding it. After one day of the meeting, after one day of using the hashtag related to this meeting, we found that nearly 700,000 sets of eyes, so nearly 700,000 impressions, were gathered by actually having tweets regarding this conference taking place on social media. So people using the hashtag, talking about it, retweeting it, etc., etc. Again, showing how far social media can actually reach in this modern day and age. And so with that, I want to close to actually say that there are very strong benefits to the use of social media, and particularly for global health advocacy, the use of Twitter, and something that we, far beyond the COVID-19 pandemic, will have to consider as one of our most essential tools in terms of actually catalyzing change, actually reaching the people that we otherwise might not be reaching. However, I want to close with some general tips. I'm sure that a lot of people are aware, but just to make sure that everybody's on the same page, is that you always have to be responsibly tweeting, responsibly disseminating your information. And you can provoke, but you have to do so in a friendly or wise manner and not by offending people. For example, my tweet on the right was a tweet which I consider provoking wisely, in the sense that this was a 2018 World Health Assembly, where on the main agenda, not a single topic was addressed to safe surgery and anesthesia care, even though 5 out of 7 people worldwide do not have access to surgical care. I raised this tweet to say if people who were here in Geneva, 5 out of 7 wouldn't have access to surgical care, would we then think about it? And they probably would. And so with that, I was trying to provoke, but not in a way that I was offending people. With this, also make sure that whatever you're tweeting, whatever you're sending out, that you assume that it is permanent. Everything you once put on Twitter or on social media or on internet as a whole will technically be permanent, because somebody might be able to screenshot it immediately before you're able to remove it. So always think twice. Make sure that you're not offending people with doing so. Be consistent, just like with any kind of messaging or advocacy. Try to spread out the information as opposed to taking one day and sending out 10 infographics, but trying to spread it out over a certain amount of time. And always try to tailor your message to your audience, whoever it may be and whatever you're trying to share. That you're making sure that you're sharing to the public that it's understandable for the public. If you're sharing it with healthcare professionals, that it is understandable and perhaps a bit more technical for them to leverage and to implement as well. So with that, I want to close, and I want to thank you very much for your kind invitation, and I'm happy to answer any questions you may have during the Q&A round. Thank you.
Now to talk on the basics of telemedicine, we have Dr. Isip-Tan.
Greetings to the Philippine Society of Pediatric Surgeons. Thank you for the kind invitation to talk to you about telemedicine, the basics. I've divided my presentation into 3 parts. First, how to choose a telemedicine platform, and there are certain considerations. Second, what are the steps in a typical teleconsultation? And lastly, how do we keep the teleconsultation safe for both physician and the patient? So people ask me, what telemedicine platform do you use? Because they'll say, oh, you know how it is, you're high-tech, so maybe you can just tell us what it is that you use so we can just copy it. But really, that's not the way to go about it, because only you can figure out what is best for you. And so for this presentation, I'm going to give you some questions that you need to answer so you can figure it out for yourself. So first, how do you intend to incorporate telemedicine into your practice? Because that will dictate, for example, the kind of investment you'll put into having perhaps a better laptop with a better webcam. Would you like to upgrade your Wi-Fi connection at home or in the office? Is it something that you're going to do only now because of the pandemic? Or is it something that you'll sustain even after the pandemic? So the second question is, to what extent and what services will you offer via telemedicine? So is it going to be part of your practice, an integral part of it? So some people are saying that after the pandemic, maybe they'll do it hybrid. Some of their visits will be via telemedicine already, and some will be face-to-face. And how sustainable is the telemedicine practice for you? So when we look at the telemedicine vendor, we want to look at the business information. So what kind of a model does it have? So we have the freemium model. So what that means is that the most basic service is likely to be free, but there are tiers or levels where you have to pay for use of those extra features. So for example, if you go to a certain telemed platform, you can do video calls, but if you want to do group calls, then you'll have to pay extra. Or if you want HD video, that's also part of the second tier that you need to pay for. Otherwise, you'll just get low definition video. So these are the features that you need to decide whether you want to pay extra for them. Second model would be subscription. So it doesn't matter whether you see 1 patient or 10 patients per month, you pay a subscription fee. Some of them instead will have service fees. So every time that you see a patient, they'll get perhaps 10 to 20% of the PF that you charge for the patient. So these are the things that you need to consider, because if the platform accepts the payment for you, then you also have to ask them, when do I get my PFs? Does it come like on the 15th and the 30th, and does it get transferred to my bank, etc.? And then we look at the technology. What hardware is needed? So is my usual laptop okay already? Does it need to have a special camera? Do I need better microphones? Do I need a headset? Can I use a monitoring device with it? Software. So usually when we talk about teleconsultations, people imagine video, but then sometimes the Wi-Fi will be not so good. So does it have a chat or a messaging function, just in case that the Wi-Fi is not so good? Is there documentation already on the platform? Does the platform have its own electronic medical record, or maybe a notes taking application within it so that you can type? How does it store and transmit the data? And then if it doesn't have an EMR and you have your own electronic medical record, is it going to be compatible? So interoperable, can be integrated, and how are we able to customize as needed? And then because we have the Data Privacy Act, we really need to look at the security and privacy of any telemed platform you sign up to. What are their web application security practices? Where is their data center? Because I remember it was an issue before that Zoom was routing the data to China. And so now they have a function there where you can choose not to have your data routed through China, etc. So what are their data center and infrastructure practices? What is the restriction of health information access? Because there are IT people, for example, at the back end of the telemed platform. Are they going to be able to see the data of your patients? So what is the policy about that? And then disaster recovery measure for health information, just in case you lose some files on your laptop. So is it going to be available in the cloud that's with the telemed platform? So customer service, is there technical support for both physician and patient? So some telemed platforms provide FAQs, not only for the doctors, but also for the patients. Because if they're not so tech ready, they will need some extra instructions on how to go about the teleconsultation. Does the vendor have a content program that offers news and information about best practices even after launch? So sometimes you have a question, can you do this? And then at least you have a place to go, maybe like a website or a forum where people ask the same questions and can have those questions answered by the users of the telemed platform or by the vendor itself. And then usability, how does it fit in the workflow? So I know of some doctors that have multiple screens. So they'll have 2 screens, one for their EMR and the other one for their telemed platform. Are you going to issue prescriptions on the telemed platform, or is that separate that you have to type in another word processing program, for example? How does it send the prescription? Is it through the telemed platform, or do I have to email it separately? So is it too complex to use, and is the interface user-friendly? Because I know of some platforms where they have a separate app for the patient and a separate app for the doctor, and sometimes that also leads to confusion. And then are there billing features? And so people ask, do the patients pay via the platform before they get scheduled? Or do I see them on the platform first and then the platform will bill them and ask them to pay? Okay, so what happens if people don't pay? So things like that. How does the platform actually go into it? And because we're going to talk about choosing a telemed platform, you need to decide what mode, timing, purpose, and persons involved will we be using it for. So there's a classification for telemedicine consultations, and the choice will depend on the context, objectives, and availability of alternatives. So for example, is it going to be video, audio, or text, or is the platform capable of all 3? Okay, and then timing, synchronous and asynchronous. So synchronous means like the patient and I will be in a video consult together at the same time, or does the platform keep the communication open between me and the patient such that the patient can type a message, for example, at 8 o'clock, and when I log on at 10 o'clock, then I can see it. So that's asynchronous. What's the purpose? Is it only for first consult or follow-up? And who's going to be the persons involved? Because most telemed platforms will look into who has logged in or access rights. So can it be that a caregiver will log in and not the actual patient, for example? Or is it going to be used for doctor-to-doctor telecollaboration? So depending on the mode, there will be benefits and limitations. So for example, if it's a video, it's the closest to the in-clinic environment. You can identify the patient and you will have visual cues and you can do inspection. However, it will be dependent on the internet connection. And if you are doing something via video, you need to make sure that you're in a private place and so is the patient. Now, if it's audio, it can still be convenient and fast and real-time, much like a video. However, there will be no visual cues, and identification may be uncertain because it's only audio. How do you know that that's really the patient, or how does the patient know that that's really you? So not suitable if visual is needed. And then text, well, if you have a chat messaging feature available on the Telemed platform, well, it can still be convenient and real time if both of you will be online at the same time. But if it's just text, it may be difficult to establish rapport unless, I don't know, use emojis. There are no visual or verbal cues. And again, identification is uncertain, who is actually typing into the messaging app. But documentation is integral because you can already see how the conversation went because it's all text. So asynchronous, well, if it's usually something that is sent not in real time, so it's sort of like a storing forward, it's easy documentation. However, non-verbal cues can be missed if it's not real time. There's no delays if it's synchronous. However, it's highly dependent on connections. Okay. You also need to weigh whether you're going to see only follow-up patients because then you have a prior MD-patient relationship, or if you're going to do it for first consults, possibly to use it as a triage for those with potential COVID so that you don't have to see them right away at the clinic because they might be need to seen elsewhere first or to do some tests. So next would be, what are the steps in a typical teleconsultation? So first we need to set up, and the setup would include the technical setup. So what device are you going to use? Will it have a camera? And if you're going to use video or chat software, you need to make sure that you have a stable internet connection and a private, well-lit location. So that would mean a minimum of 2 Mbps per user if you want an HD video of 720p and at least 30 frames per second. Otherwise, if your Wi-Fi connection is lower than that, then you're going to get choppy video, freezing video, etc. So aside from the private, quiet, well-lit room, you need a comfortable seat. So I've been doing teleconsultations since April or May. And if I see, for example, 6 patients, that's easily 3 hours if I give them 30 minutes each. So you need a comfortable seat. You need a secure table platform. Because right now, my laptop is perched on a stack of books so that I can at least have some sort of eye level to my camera. Please use white light, not incandescent. They're saying that you should have a single color background. So if you're going to repaint your home office, they're suggesting a flat, light blue paint. But most of us will use a virtual background. However, most telemed platforms don't allow the use of a virtual background as far as I've experienced them. And you also need to eliminate echo. So I don't usually wear a white coat, but some people want to wear white coats. Just know that white coats and light colors can increase reflection and glare. And sometimes you may also get glare from your glasses. The angle and vantage point might emphasize bad posture or fidgeting, so please try to avoid that. right now I'm recording this via Zoom, so there's a picture-in-picture. So I have to resist the temptation to look at it and instead look directly at the camera. And you need to do that so that the patient feels like he or she is really talking to you. So you may or may not wear headsets for privacy. So it really depends where you are, so that people can't hear what your patient is saying, I guess. So usually we'll have a setup where these are the things we need to do before the teleconsult, during the teleconsult, and after. So in the before, that's where you have the setup. Then we also have to select the patient, and I'll talk more about the suitability of patients for teleconsultation in a little while. But then we also have to prepare previous records because documentation is important. And I've had the experience where I couldn't access the EMR from my house because the clinic wasn't allowing VPN access, for example, because of fear of data breaches. Then checking the connection. Elsewhere, they allow the patients to log in like several days before so that they could check the connection and walk the patient through. But locally, I'm not able to do that. So when they log on, that's when I talk to them. Can you hear me well? Is my audio okay? Can you see my video, etc.? And then we have to give introductions because the teleconsultations are done at home. So sometimes there are other people there and we'd like to know who else is there. And then make sure that you have the consent, and I'm going to show you the consent form in a bit. So that should happen before the teleconsultation. Now, during the teleconsultation, you need to determine the agenda or agree on what will be discussed. Personally, what I've been doing is to ask them to come up with 3 questions at the time that they are scheduled for an appointment with me. I need to explain the process to them because sometimes there are limitations. So for example, what is needed for diagnosis and treatment, and when I elicit history and PE is going to be a limited PE. So I might be seeing a patient for diabetes and then the patient complains of a headache and I can't do a neurological exam, or at least I can't do the complete one. So I have to explain that to the patient. And then we need to get patient feedback as well, and I have a template that I can show you later so that we know what the reaction is to having a teleconsultation, because we cannot assume that everyone would be happy with the teleconsultation. So after the teleconsult, we need to summarize, and the reason for that is we need to ask for clarifications. Sometimes our patients are too polite. They don't tell us that we went shopping or disappeared for a while, and then they miss some part of the explanations or our instructions. So we need to do that. We explain the plan, the e-prescriptions and the lab requests. I usually send that via email, and then you arrange for the follow-up. So we talk about, do you want to do this again via teleconsultation, or next time do you want to really go to the clinic knowing all the quarantine restrictions, etc. And then very important to give the red flags when an ER visit might be needed. Because sometimes people will delay going to the ER because they're so afraid, but then you need to give them a list of the conditions wherein they need to go. And then when you end the visit, don't forget to thank the patient. And I have read several literature where they say, please wave goodbye to the patient as well, because we want to avoid what they call the doorknob moment. So if they were at clinic, sometimes they've stood up already, they have the hand on the doorknob, and then they turn back and say, oh, doctor, I still have another question. And that's something that might not happen in a teleconsultation, because then we've already left the virtual room. So after the teleconsultation, so usually after the video consult is done, I would complete the documentation. I'm unable to write or type on my laptop while I'm seeing a patient. So I only type very small short phrases, and then I just, make the longer notes later. I don't know how you're able to do it, but they're saying that if you need to turn away to type something, you also have to tell the patient, so the patient knows that you're doing something and not ignoring them or not paying attention to them. And as I've said, email a summary in our prescription, and I know some people even use password protection for their emails. So the last part is, how can we keep the teleconsultation safe for all? So the first thing I'm going to tell you is that we need to determine in what circumstances for which patients is telemedicine going to be useful. And I know that you're a pediatric surgeon, so we really have to sort of like list down who are the patients. And I'll show you a bit of some examples. So here, for example, it says, telemedicine may be useful to assess, reassess, or monitor known patients. So if it's just to adjust medications, check adherence, or answer simple questions. Or if you ask for some tests, so they need to share information on additional tests, especially when normal. You don't want to have them come in knowing that there's a pandemic. So we want to avoid unnecessary hospital visits. Some of them don't really need a consult. They just need your opinion to refer them to another specialist for specific conditions. To reduce in hospital time, I was thinking for surgeons that might be, right? So if you did the surgery and you wanted to follow them up, but it would have been inconvenient to make them go back to the hospital right away because they've had the surgery. So maybe you can do a teleconsultation to at least see them in their homes and have the caregiver, like the parent, you can talk to them and allay anxiety, for example. So it's monitoring after discharge to facilitate or redirect healthcare if there's a long waiting time. And of course, if they're in some isolated area where it's difficult to get to a hospital. So much has been said about the virtual physical exam, and in our MIU guidance document, we have this infographic. And this infographic is limited by the fact that this was from a literature review. I have been talking to some of our clinicians, and they have other sort of folk wisdom, or maybe because they have the clinical eye, they're able to do other things than what is here in our virtual physical exam infographic, but definitely will have limitations as far as palpation, percussion, or auscultation. And so I am seeing literature now where they have infographics for the patients to study, so that during the teleconsultation, if you tell them, I want you to do this kind of maneuver, more or less they receive information on how to do it before the teleconsultation. Now, to keep the teleconsultation safe, we definitely need to verify the identity. A teleconsultation cannot be done anonymously, and especially so if it's a first consult. And it goes both ways. You need to verify the identity of the patient and the identity of you as a doctor. The patient must know that you're a real doctor. We need to protect confidentiality and obtain informed consent because of the Data Privacy Act, and it cannot be implied consent. So you really have to have it written, electronic, or recorded. So, and it has to be freely given. That's part of the specification in the Data Privacy Act. Consent of the data subject refers to any freely given, specific, informed indication of will. And so there has been some discussion. If I click on this button or tick this box, does that already qualify as having given express consent? So that's why when you have your consent forms, make sure that they are reviewed by the legal of your hospital or your clinic. So in the MIU guidance documents, we have a consent form template, and it's about 3 pages long. And people have told me it's too long, but then it has the following parts: the introduction and purpose, the nature of the telemedicine consultation, the benefits, potential risks, data privacy and confidentiality issues, and the rights and limitations. So that's why it's that long. So we have it both in Filipino and English, and here you have a partial screenshot, and you can download it from this link. Now, people have asked me, can we record the teleconsultation? I would personally advise you not to, because then you'll have to be responsible to be protecting that data. And if you think about it, it's sort of like part of the electronic medical record if you do that. So then we don't have the laws for that, but if we assume that it's part of the hospital record, then you have to take care of it for at least 15 years. And it says here that I understand, or I trust that my doctor will do his best to keep the recording safe from theft, corruption, loss, illegal use, or sharing on social media. So I think it's too much responsibility. So I would say don't record. But if you do, there's a separate consent form for that. Now, we also have a documentation template. We all have our own. Is it SOAP, or do you have a full-blown EMR, for example? But there are certain things that you need to document in addition. So for example, you need to document that you have the consent, and then if there are limitations that arose during the teleconsultation. So for example, patient complained of abdominal pain. However, I was unable to do an abdominal PE. So here's what I did. I gave the patient a referral, or I scheduled for an ultrasound, etc. So you have to put it there as part of the record. So what were the measures done to address them? Or the Wi-Fi of the patient suddenly got cut off. And so now we shifted to a phone call or an audio call, etc. And of course, then you need to write that as well. We don't know when we're going to get reimbursements for teleconsultation, but if you do, following the models elsewhere, they really have to put the date, the time, and the duration of the teleconsultation. Sometimes really also need to put, and because you're pediatric surgeons, I suppose there will be like the caregivers, the parents, etc. You need to put down the attendees present. Okay, was it caregiver, relative, another healthcare provider at the patient site? Was there a surrogate decision maker, etc.? So we just need to document all those. And when I say encourage feedback and monitor outcomes, because we're really going into this because of the pandemic, and I don't know how it's going to be after the pandemic, but we need to monitor outcomes. Was it really safe for the patient that I did it via a teleconsultation? Did it add on to the care pathway such that an actual face-to-face was avoided? But in terms of feedback, we asked the patient, well, did you find the scheduling okay? Was it feasible or convenient for you? Were you satisfied with the care that you received via a teleconsultation? Now, the e-prescription, we're also waiting for more durable legislation because right now we only have the FDA circular for the COVID-19 pandemic response, which defines what an e-prescription is. So it could be optical electronic data like PDF, JPEG, or other photo file format that can be sent to the patient. And that the electronic prescription is equivalent to a written prescription. And so therefore, when you send this to the patient, you must keep a copy for yourself so that it will be in the patient's medical records as well. Now, I send a teleconsultation summary of what we talked about via email, and that allows for correction of discrepancies and any misinterpretation. So that's also to protect you and for the patient's safety. So I've heard stories where the instruction was to do a warm compress, but since it was an audio call that was not documented and the patient did a cold compress instead, so now it's the word of the doctor against the patient. And what if something happened to the patient? So we really need to be more careful about our documentation and to send a copy to the patient. And that might include not only what transpired during the teleconsultation, but also what are the most next important steps like tests, referrals, etc. So that's actually my last slide. And since the pandemic is on how many months already, so I suppose most of you have tried teleconsultation, and I'll be happy to answer some questions if you do have any. But if you haven't seen our medical informatics unit guidance documents yet, they're at bit.ly/UPMIU Telemed 2020, and you all can also reach me on Twitter or via email. Thank you very much.
Let us welcome our last speaker, Attorney Rebosa.
Or Dr. Vervoort and Dr. Tan, when they lecture on something good. In fact, Dr. Tan enumerated and clearly explained the technical aspect of how to perform or how to do your telemedicine consultation. My lecture will center on what happens next, meaning to say, if something goes wrong and the patient would want to sue the doctor. So we might as well know also the legal and ethical impact of this telemedicine consultation or telemedicine practice among us physicians. Okay. Now, before we start, you must be reminded that you must also have some familiarity with the basic laws that we have in our country. I'm sure you know of the Medical Act of 1959, a law that governs our practice way back 60 years ago. And this law can hardly cope up with the changes of times, much more with the advent of this telemedicine consultation. I'm sure that you know what Data Privacy Act of 2012, as lectured briefly by Dr. Ratan, and Republic Act 11332, or the Law on Reporting of Communicable Diseases, and the one that you always hear in the radio, the television, and the news is the Bayanihan Tuilas 1 Act. They are now trying to enact the Bayanihan 2. And of course, you have to be well versed with the protocols of your hospital and the guidelines and policies of your specific specialty society, in your case, the Philippine Society of Pediatric Surgery. Now, just briefly, the Medical Act of 1959 actually enumerated or defined the acts constituting practice of medicine by way of enumeration. And briefly, this is to physically examine any person, diagnose, treat, or operate, and prescribe, whether for a fee or not. That's under paragraph A of section 10. Paragraph B actually stated here, any other means of communication, either offer or undertake by any means or method to diagnose, treat, operate, and prescribe. But take note, this law was enacted way back 1959, and the spirit of the law is that it did not include your telemedicine. The big question now is telemedicine to be considered an act constituting practice of medicine? It can go both ways. We can actually use this for or as a defense when a case is filed against us. Now, let me just define briefly what telemedicine is. I'm sure it was also defined already by Dr. Vervoort and Dr. Tan. It's actually the use of advanced telephone technologies where medical information is exchanged from one site to another via electronic communications to improve patients' clinical status. With this telemedicine, we also have the telephone medicine, meaning to say you only use a plain phone call, no video. SMS consultation, plain exchanges of text. And as I will lecture a little later, I am not actually a proponent of SMS consultation. I really do not encourage doctors to do just plain SMS consultation because of its legal implications. Now, the DOH NPC, or the National Privacy Commission, they define telemedicine as practice of medicine by means of electronic and communications technologies. That is, you use your phone call, chat, or short messaging services, or the SMS, and the telemedicine that we do now is the audio and video conferencing to deliver the diagnosis, the treatment, and the e-prescription. Now, who can practice telemedicine in our country? Well, of course, any licensed physician of the PRC can engage in telemedicine. In fact, the DOH NPC already made a joint circular memorandum recognizing licensed physicians to engage in telemedicine despite the absence of physical contact. But take note, they categorically stated there that the gold standard for clinical care still remains to be a face-to-face consultation. And likewise, the DOH NPC also mentioned that telemedicine shall only be employed by a licensed physician when he is physically inaccessible, such as during national emergency, and as of now, it's due to the COVID pandemic. Much has been said, how clearly explained by Dr. Ratan, but here are the problematic areas of concern that may lead to litigation after telemedicine. The big question is, what happens next after your telemedicine consultation? Most often than not, there is prolonged or delayed diagnosis. You were not able to see the message. There's poor documentation or inadequate records, because as doctors, let's accept the fact that most of us are not that into technology. Well, I'm not saying everyone. I myself is not really good in technology. Misdiagnosis because you failed to get a thorough history. Technical problems. SMS miscommunication, especially for pediatric surgeons and pediatricians. You type in your message, it should be 0.5. You forgot to put the period before the 5. The patient now will give 5 instead of 0.5, and that could lead to uh, dangerous effects on the patient. And that is actually now a clear evidence of what you had texted to the patient. It becomes, it is now communicated and documented that what you texted is 5 rather than 0.5. Privacy and confidentiality issues, the prescription, and how do you charge? I think Dr. Tan explained how to charge, uh, and the taxes. How do you go about the taxes of the professional fees? That's also one thing. And what I'm afraid of is that, as it was mentioned, you have to get the identity of the patient, and that is very, very important. But more than that is also to take note of the location of the patient. Telemedicine can be from Jolo to Apari to Batanes to Babuyan Islands. Now, on a legal point of view, a case can be filed against a doctor if there was misdiagnosis or negligence through this telemedicine in the place of incident or at the address of the patient. So you have to take note likewise. Your patient is from Mindanao, your clinic, and having the telemedicine in your clinic in Quezon City, take note that the patient can actually file the case in their address, which is Mindanao or far-flung areas of Luzon and Visayas. So that is also one subject of concern in telemedicine. Consent. As far as pediatric surgeons are concerned, your patient is a minor. So the consent must be provided by the parents. The order of getting the consent is very, very important. The patient is the one to give the consent, but in your case, it's a minor, so the next in line would be the parents. For illegitimate children, the mother would be in a better position, or the one who should give the consent. For legitimate children, it can either be the father or the mother, but it's very important to likewise identify who the parents of this patient is. You have to be very careful not to get the consent only from the yaya, from the siblings, or lolo or lola. It's very important that you get the consent from the parents, unless, of course, there are instances where the parents cannot provide the consent. Then the next in line now would be the grandparents. Without the grandparents, the siblings and the nearest relative. That would be the order for the consent. Now, as it was clearly explained and lectured by Dr. Tan, waivers and consent are very important. In fact, there was a slide regarding a good consent. Waiver and consent is very, very important, and it has to be documented. When we say documented in telemedicine, there are tick box, or you have to take whether the patient already consented. Some doctors would do this. They would even provide a separate consent form on top of the consent form provided by the platform, and they will have to sign it and scan it and send it back to the doctor before they will continue the telemedicine consultation. And of course, you maintain confidentiality and good rapport, the in and outs of how to make good of a telemedicine consultation. And of course, you have to still comply with the standard of care. When telemedicine consultation is no longer applicable or it's no longer appropriate, then you have to refer the patient to a face-to-face consultation. Now, this was already mentioned a while ago, the consent or waiver consultation. For me, it's very important that the consent would include that this is not a substitute for regular or face-to-face consultation. And it will not eliminate the need to see a doctor under the circumstances. Likewise, it would be better if you put there that the doctor and the medical staff shall not be liable for any incomplete or inadequate treatment or misdiagnosis if the same was the result of having withheld any material information or due to the inherent limitations of telemedicine consultation. We have to accept the fact that telemedicine consultation is not a substitute for face-to-face consultation, and that you also have to put in the waiver the rights of the patient under the Data Privacy Act, and that the consent to collect, store, access, and share process personal data and medical information, whether manually or electronically. And take note that you should be reasonably compensated, which must be settled in the most expeditious and judicious manner. In fact, this is a problem for us. As was mentioned a while ago, how do we get paid? Would it be on a 15:30 scenario, or right after the consultation to be transferred to your account? It would really depend on the platform you're using. Now, just briefly, under the Data Privacy Act, you should take note this the processing of this personal data should always adhere to these three basic principles. Take note, it should be transparent, and it's for a legitimate purpose and proportionality. Meaning to say, you need to get the information from the patient that is really necessary for the consultation, examination, diagnosis, and treatment of your patient. You cannot go beyond that. You cannot make use of the platform as a means to get other information short of violating the privacy of the patient. Next slide. Now, the Data Privacy Act is very specific and categorical in stating the instances where this sensitive personal and privileged information is allowed. And as doctors, we were included in that. Take note, the processing is necessary for the medical treatment and carried out by a medical institution, and an adequate level of protection for the personal information is ensured. Okay, but take note, as mentioned a while ago, the data subject or the patient must give his or her consent, whether the consent from the platform coupled with your private consent. Now, you have to take into consideration likewise, under our code of ethics and under the law, the right to confidential information of the patient. Take note that under the law, we cannot divulge any information to anyone except in the interest of justice in the course of our doctor-patient relationship. Under our code of ethics, it is the same. We cannot divulge even after death. It is deemed sacred. So you have to protect that. Otherwise, the doctor can again be liable criminally, civilly, and administratively. Now, during this pandemic, there have been a lot of issues whether we can actually divulge our patients who are COVID-19 positive. Now, under the National Privacy Commission, take note, the employer or even us doctors may not freely disclose the identity of the COVID positive patient. What we can do is to make necessary notices internally, but without disclosing the identity of the person. This is what actually is making it very difficult to control the COVID pandemic, because the only authority that can do proper contact tracing is the DOH. We have to disclose the identity of the patient to the DOH, and it is already the DOH who will cascade the procedures in order to contact trace the COVID-19 positive patients. The DOH is likewise empowered under Republic Act 11332, or the Law on Reporting of Communicable Diseases. It has to be reported to them, and as I've mentioned, it will be the DOH who will do the contact tracing as mandated by law that the COVID positive 19 patients have been reported. So when you have patients who are COVID positive patients, you cannot just divulge it to anyone. The DOH will be the one to effect the contact tracing. Okay. Now, I'm on my last few slides. Well, as doctors, we were not ready for this. In fact, no one was ready for this COVID pandemic. But just the same, as doctors, under our code of ethics, we are here to serve humanity. And before the pre-COVID, we were already having this threat of suits, increasing threat of suits. And now we have even this threat to our health in treating COVID patients. And likewise, also the threat of litigation in treating COVID patients. But as mentioned in Psalm 23, I would like to read this. Though I walk the valley of shadow of death, I will fear no evil. That's how we should be as doctors. We are here to serve humanity and to be still ever present in providing our health care to our patients.
Let us welcome back our three speakers for the Q&A portion to be moderated by Dr. Tagayuna.
Good morning. It is my pleasure to be the moderator for this very interesting and timely webinar, and an honor to serve in some small way our esteemed colleague, leader, and friend, the late Dr. June Resurrection. I am Dr. Dures Tagayuna, pediatric surgeon from Cagayan de Oro City. For those attending, just a few reminders. Please type your queries on the question and answer box. Indicate if you'd like to direct your question to a specific speaker. You may also opt to raise your hand, and we will allow you to ask your question during the panel discussion. Please be ready with your question to facilitate a faster transition once you are called and asked to unmute yourself. Please check also if you have inadvertently raised your hand during the course of the lecture. Lower your hand at the start of the question and answer portion so that we won't call your attention to speak. So, Dr. Dominique, let me start with you. Thank you for sharing your extensive experience with insights with social media that covered even beyond this COVID era. Indeed, it is a viable tool for health education, global health advocacy. We are all within sound bites of each other. Here's your first question. Do you have experience in utilizing Facebook instead? In the Philippines, we have significantly more Facebook users than Twitter.
Mm-hmm. Yeah, thank you so much, first of all, for the great set of talks and for the invitation to be here amongst you all. This is a great question, obviously, and various platforms, various social media platforms have various opportunities, different target audiences, and obviously also regionally a very different focus with, for example, a bigger focus amongst the public in the Philippines compared to, for example, in Belgium, where other platforms would be more utilized. Specifically for the topics that I've addressed and then mostly pertaining to the global health advocacy on the pediatric surgery side is that I focused on Twitter mostly with a focus on high-level advocacy, so really trying to influence policymakers, like for example at the Ministry of Health, at the United Nations, at the WHO, etc., as well as the media itself, all of whom are typically much more active on a platform like Twitter compared to, for example, Facebook, where it's harder to reach them given the fact that you either need to be connected or they actively have to be reading the comments on their pages. Now, for example, on a platform like Facebook, there's other opportunities, like, for example, public advocacy amongst patients, amongst other healthcare professionals, within communities such as Facebook groups, etc. And so various platforms definitely have their different opportunities and different benefits to them, but it's really dependent on what the target audience is or really what the end goal of the advocacy or the activity is that you're engaging with.
Just a follow-up question to that. How many is following you, Dr. Dominic, on Twitter?
I think approximately 5,000.
Okay, and then you get how many tweets a day? Will you have responses or something like that?
You mean that I put out myself?
Oh, yes.
Well, it varies. I would say that I tweet about 5 to 10 times a day, depending on what I have to say that given day. But obviously that's really dependent as well, whether there's a conference or a meeting, etc. Typically around those times there's much more engagement because more people are active on social media, more politicians, more policymakers are active, and that's really the moments where you have to take advantage of them being active and trying to reach them for topics that they otherwise would not be talking or thinking about as well.
Okay. Dr. Iris, I know you have something to say. I'd like just first to say thank you for sharing your take on the basics of telemedicine. It was a refreshingly comprehensive, yet you broke it down to chewable parts for us neonates. It indeed shows you are a techie in the sea of non-techies, what most of us would like to be during this time. So you have a similar question, and I will just read this so you can answer connected to that. Since you are also actively using social media platforms to reach colleagues and patients, what is your experience in Facebook versus Twitter in the Philippines? Do you think there is some sort of intellectual divide where Twitter is more professional and Facebook is more for lay people?
So I would agree with Dr. Dominique that it really depends on the purpose that you're using the platform. Recently, since I'm an endocrinologist, we published a paper about the use of Facebook for a social media campaign on diabetes. Because as you know, those with diabetes are at high risk for complications in COVID-19. And we were able to demonstrate that we really had a wide reach and a good engagement rate. So we have not done that for Twitter. Simply because there are more Filipinos on Facebook. So that's what we tried. I am on Twitter similarly to Dr. Dominique because of my personal learning network. So we just concluded, the Philippine College of Physicians just concluded its virtual conference. And I was checking our hashtag on Simpler, and we were reaching millions in terms of reach. So it's really a good platform if you want to have a good reach.
Thank you. Thank you. Let me ask the first question of our Attorney Abbott. Sometimes you get scared about when you talk about law, Attorney Abbott. But thank you. As doctors, I think you know very well that we are usually afraid of the wrong side of the law and we toe the line too often. But we can't say that of everyone, and violations of the laws, you mentioned, is commonplace, right? And sadly, just a handful reaches to the courts. My question would be, how do you ask for, the question here is, how do you ask for consent shortly? And some telemed AP apps have waivers and some have none.
Well, by the way, before I answer the question, let me thank everyone for inviting me. I was cut a while ago because of my unstable connection. Again, the consent, as mentioned, I really agree with Dr. Iris that consent. In fact, unlike in our setup in the clinic, when the patient is inside our clinic and we start exchanging communication, that is already an implied consent. However, in teleconsultation, it's not a face-to-face. It is for the protection of the doctor and the patient. Both of them are protected with this consent form. Without the consent form, we don't have any documentary evidence that we can use, if at all it reaches the court because of some misunderstanding during the teleconsultation. Now, insofar as the consent form of the platform, you have to review it. If it's already extensive enough, comprehensive enough, then you can do with that. But other doctors, on top of the consent form by the platform, they likewise provide their own consent form, which is, I don't think, I will agree with that. I don't think there's nothing wrong with it. It's a sort of defensive practice of medicine, so to speak.
Okay, I think you have a follow-up question. What is the extent of our legal liability if we post on social media some information that the patients or even doctors eventually use and a legal problem arises?
Well, at this point, it has been clearly explained both by Dr. Dominique, Dr. Iris, and myself, the confidentiality issues. We cannot post information of patients on social media unless, of course, the patient will consent to it. We have to take note that the social media can be read by all, for all parts of the globe. Now, if you post this without the consent of the patient, you can be liable for breach of confidentiality. You can be administratively liable, meaning to say your license can be suspended or revoked, or at the very least you get a reprimand. If something derogatory was posted out of the information of the patient, that can also be a crime, cyber libel. So as much as possible, I encourage doctors not to post any information of patients on social media, unless, of course, you use it as by way of during conferences that the patient cannot be identified. Make it hypothetical. Make use of patient X, patient B, and that this information cannot be linked to identify a patient.
Okay. Then I go to my next question. Dr. Iris, you talked about doing a cloud-based telemedicine, and how safe is that then with data privacy?
Okay, I think Attorney Rebosa can correct me, but when I was attending the data privacy hearings, for example, they were saying that standard security measures should be applicable. And as far as I know, those cloud platforms will have the most security applied to it because they know it's very vulnerable. Having said that, there's nothing that cannot be hacked. And so the National Privacy Commission was very reassuring when I heard them say that we're not going to punish all data breaches if you can show us that you were actually putting down the usual safety practices. If you weren't, that's when you can be liable. Is that correct, Attorney Rebosa?
Yeah, I agree, Dr. Iris. As long as you have measures to protect the information, that is all what we need, because there is no technology that cannot be hacked. Absolutely. There's no perfect safety measures. But if your platform does not even have any safety measures for protection against breach, then that would be the time that the platform and the doctor can be held liable for breach of privacy.
And Attorney Abet, would it mitigate your case if you had done something as soon as you knew there was a breach, you took measures to control or say something to the ones who were affected? Would that mitigate?
Well, it will not only mitigate, it may even absolve you of any liability.
Okay, thank you. Dr. Iris, you have another question. What do you do with patients who keep on sending email follow-ups?
So I think in the Q&A box, I sent an example of an automated responder, what I have in my email. I have not had a lawyer look at it, but for me, it's just the most practical way to explain to patients that I have a process in the clinic, and the process is to schedule a teleconsultation via my secretary. Of course, they will get the email because when I send the request, they know that's the email of the clinic. So sometimes they will reply there. Okay, so I'm just basically telling them this email is not actively monitored. So please don't send emergency questions via this route. And I think what helps me is I don't see new patients via telemedicine, only follow-ups. So we know each other very well. And I think when you have that kind of rapport or relationship with the patient, they tend to follow what the rules should be as far as how you run your clinic.
Dr. Dominique, do you have such a concern also with your practice? Do they send emails to you or call you or send you SMS?
For me, no, since I'm currently in my academic time, so I'm currently not treating patients actively, so I don't have that issue at this given time.
Okay, we have another question. There are some patients who would do online consult from other doctors and then ask me to sign a document for their claims, SSS, sick benefits claim. I did not see the patient nor know his or her history. Can I sign their claim form? Will I be legally liable for that? Attorney Abbott?
Well, first, if you affix your signature to any document, you have that responsibility with that document. So you can be held liable if something is wrong with that document. Insofar as they consult you just for the plain reason of having this document signed, you have to still do everything within your means to investigate. If you think that by way of that consultation you can sign these documents, then by all means you can sign it because you can explain what you signed. But if you are not comfortable with it because another doctor has already seen the patient, you can always refer back the patient to the previous doctor, because in that way you can actually transfer the liability to the previous doctor and escape the liability of having to sign that document. And as a matter of fact, you are only a substitute to sign that document.
But Attorney Abbott, that usually happens to our relatives, right? They went to somebody.
Yeah, always.
Anyway, this is what happened.
Yeah.
What do you
Well,
do?
if it's a relative,
Okay.
and you trust your sign that this document is, and everything is in place. But if that is, you don't even know the identity of that patient, we can actually choose our patient if it's not an emergency. Is, and it's not wrong to deny patient to sign these documents because this is not an emergency.
That's true. That's true. We have another question. I think, Dr. Iris, will it be advisable to utilize multiple platforms? What are the advantages and disadvantages?
Okay, the advantage would be, I recognize now because more people are doing telemedicine, that if you wanted to refer to another colleague who's also doing telemedicine, it's an advantage to have that colleague also in the same telemed platform. It's just for ease of referral. However, if you really want to refer to someone else and he or she is in another platform, then you might consider having two platforms. But that's really where the difficulty lies now if you want to be doing that. So if you have limited tech capabilities, now you have to study so many platforms.
The other thing you have to consider also is resources. Do you have a ballpark figure of how much it will be to start such a telemedicine from a private clinic, like cost for software and hardware?
I really don't know because I'm in a solo practice and I'm using a platform that actually has a free model. I subscribed some months back and it's around $35 a month for a solo practice. So of course the cost will escalate as you have more doctors and then you need more computers, etc.
Yes. All right. Dr. Dominique, you said in Twitter it can be a platform high-level advocacy and you should responsibly tweet and provoke wisely, right? But the experience is whether we do it wisely, kindly, or anything, there's always a basher out there or bashers. How would you deal with that?
I think that's a great question, and that's unfortunately just like with misinformation. That's a bit of the downside of social media, is that there are people who are using it to entice people or to lure them or to troll them, or whichever verb you want to use for that, which is generally the case. It's just better to ignore it if it's something where okay, this is an unreasonable situation, or this person is being very offensive or is being going off on a tangent, because typically when you give them more attention, they'll just escalate because they know that they then caught you and they'll know that you'll continue to respond. So I think in those situations, it's better to hold up. However, if you feel it is a situation where there was a misunderstanding or where you potentially may have said something offensive and somebody has been offended by that, I think it's also very important for you to consider that and see both sides of the story. And if you are indeed in kind of the faulty position, to recognize that and respond to that and rectify that.
Okay, thank you. Can I just go to Attorney Abbott? If we do have a basher or a stalker who clearly has violated all the laws that you have listed for us, the question is, how long and how much will it cost a doctor to pursue legal punitive action? Should we? Or is this a waste of time and money?
Well, I will agree with that it will be a waste of money and waste of time. But you see, it really depends on the personality of the doctor. Some doctors wouldn't care how much they will spend or how much time they will have to pour into it, as long as they can have this person be punished. But knowing the intricacies of our judicial system in our country, it will really take that long. It's not as easy as you file it today, by next month it's
So maybe it can be like years
done
later.
with. It will have to go through due process, as you always hear that. Years can be, yes. And sadly enough, with all due respect to the legal profession, while the case is pending, you are paying your lawyers for legal expenses.
Yes, so that's why you're paying a lot, not only to court but also your lawyer. Okay, so there's another question. Do you recommend compartmentalizing using Twitter or medical related advocacies and Facebook for personal or non-med related or separate Twitter accounts? Dr. Iris?
Okay, so here's how I started. I have my personal Facebook account where I have my family and friends. I have a professional Facebook page because I have an advocacy for health promotion. So I explain endocrine conditions in Filipino on my Facebook professional page. Then I have a Twitter account for my personal learning network with colleagues. However, if you check my Twitter feed, sometimes I have political opinions there. I cheer for my basketball team, etc. So I think it's sort of like, it really depends on what kind of personality you want to project when you're there on Twitter. Because I also have a tweet chat that happens every Saturday. And then we know that when I'm in that tweet chat, we're doing it professionally. We're talking about medical topics. But outside of that, it really depends on your comfort level.
Dr. Dominique, you had a term for that where you just give, you don't give too many tweets in a day?
Well, to basically kind of spread it out as opposed to all getting it all together. But yeah, I definitely agree with that sentiment in the sense that Facebook is generally more used for reaching, for example, either your personal contacts or kind of more the public, such as, for example, in this case, families of pediatric patients or the parents thereof. Whereas, for example, the use of Twitter could be very helpful for, on the one hand, high level advocacy, obviously, but on the other end, also more kind of from an academic perspective, connecting with healthcare professionals from around the world, staying in touch with kind of more the recent literature with online meetings and things like that. So there's definitely different purposes. And also for myself personally, I've also tried to use different platforms for such different purposes as well.
Okay, thank you. I think we go to Attorney Rebosa again. Is it illegal and ethical to post on social media your teleconsult platform for them to utilize, or like maybe it's an advertisement of your clinic and ours and that?
You can do that. Actually, our code of ethics allows us to advertise insofar as our clinic schedule is concerned. So in a way, in the same manner as you provide business cards, as long as the advertisement in this platform or social media is specific, your name, your field of specialty, your clinic hours, and the platform.
Okay. What can we do as physicians to protect ourselves from posts of patients who identify a specific doctor? Oh, doctor shaming.
Yeah.
What can you say about this?
Well, we cannot actually protect ourselves from this doctor shaming. The only protection that we can have is really to go after these persons shaming doctors. Just last week, I was with the medical director. The professional fee was the hospital expenses was only like about 30,000, and I told the medical director that it would be a waste of time and money, as you mentioned a while ago, Doctora. But she was really keen on filing cyber libel against this patient, and we always try to convince doctors and hospital to start filing cyber libel against this person. So it can, if it will not put a stop, it might actually lessen or even abate this doctor shaming of patients.
We need
social media.
Attorney. We probably need somebody who's a brave soul or a brave institution to go through the works on this.
Yes.
Right? Okay, we have some raised hands in the audience. Can we ask Vanji Bautista to open your, to unmute yourself and give your question? Just direct it to who you want to ask. Vanji Bautista, unmute yourself, please. All right.
She's
I
not
think
responding, ma'am.
okay, Lorilyn Mandigma. Lorilyn Mandigma. Or Christine Alcazabas Gonzalez. We can get back to you in a little while. Attorney Rebosa again. Some surgeons would post pictures of themselves in the OR describing a rare or complicated case. Well, that's really something for us. Although they don't show any identifiable body part, saying they got verbal consent from the patient. Is that enough? Will they still be liable in case the patient complains?
Well, I would have preferred a written consent because, as mentioned by Dr. Iris a while ago, if it's only a verbal consent, you don't have any documentary evidence to show. If it goes to court, it would be the word of the patient against the word of the doctor. If there was a written consent, I would be more comfortable. But just the same, I actually don't encourage doctors posting themselves with patients, especially if the identity of the patient can be traced. Example, the face of the patient cannot be seen on that picture, but there's a date, there's the hospital, so you can actually trace who that patient was during that operation. So even if there was no direct picture showing the face of the patient, but the circumstances of that picture that you can trace the patient, that can still be a cause of concern for breach of confidentiality.
Yes, like you say, we are so proud to say this is our first Whipple's procedure, and that's really going to
that's it. And then you know who the patient is because that's the first. Yeah.
Okay. Yeah, okay. Sir, you have another question. Have you had any case concerning dealing with teleconsult? This is from Dr. Wilma Baltazar, our past president. You have any cases concerning teleconsult?
It's more of a consultation, but not in court yet. Meaning to say they have this encounter with this patient, and what should they do?
Can you tell us some details about that? Are you at liberty?
I cannot divulge at the moment, but it's more of the consent issues, the basic issue of consent.
Okay. Dr. Dominic, is there an official way to cite Twitter posts as references, or they do not qualify as such, like in formal communication or formal research or something?
So they are increasingly being accepted as reference as well. It will definitely be dependent on the journal itself or whoever you're submitting that reference list to. But generally, and especially if you're using your computer, you can use Twitter as basically as a website, and you can use a reference a tweet or a post as a link that you're then referencing to, like you would for another website, like for example by the PSPS, or for example from a blog or a newspaper, etc. And so you could cite to that in that way as well. Although I would definitely, if you're using a citation from Twitter, I would definitely check whether there's any guidelines specific to that from the journal itself or from whoever you're submitting it to, because some people might accept it and some might not.
Okay. I think this is for you, Dr. Iris. Any information about encrypting files and documents with patient information available? We do not see it practiced too often in the Philippines.
Oh, it really depends on what you're using to document. If you're using an electronic medical record, they will have encryption. So maybe the one asking question is if you're doing it on a Word document, uploading it to a Google Drive or something, then definitely there's less encryption that way. So I would advise you to keep your very sensitive information, and under the data privacy law, any health information is highly sensitive. You should put it inside an EMR, because I would assume that an electronic medical record system will have the strictest safeguards for encryption.
Okay. If they're selling EMRs, they should do that, because otherwise we can also sue them, right? Yeah. Can I just go back to the raised hands? Banji Bautista, are you available now? Or Lorilyn Mandigma? Or Christian Alcazabas Gonzalez? Okay.
Baltazar has a question, I think.
Yes, go ahead, Dr. Baltazar. I don't see her, but Dr. Wilma?
She lowered her hand now. Sorry.
Okay. Sige. So, Attorney Rebosa, is getting a malpractice insurance policy nowadays does it protect a practicing surgeon financially or psychologically from a litigation? And what is your opinion about this? Malpractice insurance policy.
Okay, let me explain. Medical malpractice insurance in our country can only be applicable if it is a civil case filed, meaning to say the patient is asking money from this doctor. But take note, in our country, a criminal case and an administrative case can also be filed against a doctor. So in criminal cases, you cannot use your medical malpractice insurance because you cannot insure criminal liability. In the same manner that your administrative liability cannot also be insured. It is only the civil liability that can be insured. So even if you have this medical malpractice insurance and no civil case is filed, that will go down the drain. Plus, if you get a malpractice insurance, you have to review carefully the provisions of that malpractice insurance. First, will they provide settlement if a complaint is filed? That would be a better malpractice insurance. There's a pegged amount for settlement. Secondly, most malpractice insurance, they will only provide the proceeds after the case has been resolved with finality. That means to say resolved by the Supreme Court after 15 to 20 years. So, you have malpractice insurance, but they will only provide the payment if you lose the case. So, doctors get malpractice insurance with the hope that they can be protected from any malpractice suits. Okay. Now, thirdly, if you get a malpractice insurance, you have to make sure that if they will provide you with their lawyers or your private lawyers, because the lawyer of the insurance company will always protect also likewise the interest of the insurance company. Unlike if you have your personal lawyer, your personal lawyer will always protect your personal interest. So at this point in time, even if you have a malpractice insurance, that will not give you a guarantee that a case will not be filed against you. In fact, it will even be a magnet for more malpractice suits filed against you. They will say, oh, this doctor has a malpractice insurance, let's file a case against him because we can get something from that insurance. So these are the points that you have to consider when you get a malpractice insurance.
So, attorney, if they filed a malpractice case against you, civil case against you, and the insurance paid for it, can you put in a caveat, a waiver there that they cannot file anymore a settlement, a criminal case or an administrative case? Is that possible? Or you're going to have to go through something?
And that's possible. In the same way, when cases are settled, we always make sure that no more cases will be filed criminally and administratively. And in the quitclaim, we call it in legal parlance, the quitclaim, we always have to put there that the doctor was not negligent in the treatment and care, and that the settlement was only out of humanitarian consideration or financial help. So that if a case will be filed before the courts for criminal and administrative liability, that quitclaim signed and affirmed by the patient will be the one to be used in court as an evidence that the patient himself or herself even already testified under oath that the doctor is not negligent. But take note, in the PRC, anyone can file a case. So meaning to say, even your neighbor can file a case against you for any alleged or perceived medical negligence from the patient. That's the problem with the PRC. Anyone can file.
That's sad.
Yes, that's sad.
Going back to the cases, can you include there also a gag order? Like, can we control chismis? Like that you were brought to court or you were being sued, but you settled. Can we put in a gag order? Because from my experience, even the lawyer is the one talking about it.
We always put there also a provision in our quitclaim that it would remain confidential. But it's really very difficult, the culture of the Filipinos. You can never pinpoint anymore who started this rumors. But if you want a specific gag order, it has to be applied in court, and it would entail again another bout of judicial proceedings, and it would not be advisable.
Right.
Anyway,
Incorporate it into the way.
we can always
Claim.
put it if they
Can you
breach,
just
but if they breach it, the one who signed it must be the one liable. But the rumors would spread from other persons not involved in that quit claim. If there's any consolation to that, after the settlement, Filipinos have short memories. They will not recall anymore who this person is. In fact, ask yourself, Doctora, who was the last doctor sensationalized in the news due to alleged medical negligence? You cannot remember.
Yeah, we're only as good as the next big story, right?
Yes,
That's
yes.
why we wag the dog. We get another big story to forget the first one. Yeah, thank you. Good day, doctors. Are there efforts by the PRC and PMA to regulate this platform to ensure that fake doctors do not take advantage, especially with the amount of fake documents and fake news in the country? Dr. Iris, how about you first? And then let's have Dr. Abbott.
Just last week, I was at the DOH UP Manila TeleHealth Policy e-Congress, and they were discussing how we should go about accreditation for telemedicine practice. So the points of contention would be, do we need a separate accreditation practice or process? Or is it like when you graduate from medical school, you automatically get accredited for telemedicine practice, which would mean that we would have to teach telemedicine competencies. And I was making the point that right now we do not have telemedicine competencies in our curriculum. That's why everyone was scrambling during the pandemic.
Mm-hmm. Okay, Attorney Abbott?
Well, as early as 10 years ago, there were proposed House bills in Congress insofar as telemedicine is concerned. But at this point, there is no law yet being signed. Because, when these bills were proposed in Congress, there was no COVID pandemic in the first place. They don't see the need for it. But there are laws in place to punish fake doctors, for illegal practice of medicine. In fact, that's the sad story. These fake doctors are getting away with it, and we licensed doctors are getting the brunt of having this alleged perceived medical negligence cases against us. So I think if Dr. Iris is always with the DOH and PRC and with the Congress, there need to be a law to address this, but not to address doctors. I think, in my opinion, once you are a registered physician, you can now engage in practice of medicine, whether it's telemedicine or face-to-face consultation, but the guidelines and policies must be put into its proper perspective for us to follow.
Okay. I agree with you, Doctor.
Go ahead, Dr. Iris.
Yeah, I agree with that, and that's the opinion I gave as well. We do not need another accreditation process, I should think.
Yes, but just as a follow-up, Attorney Abbott, like for example, you have a patient who came in with a big complication, and they came from somebody like a fake doctor. But you do not want the trouble of reporting, right? You don't want to go to court and all of that. Can we report anonymously? And is that possible that they follow it up and do something about it?
Well, it would be very difficult on the part of the investigative agency or the police when you report it anonymously. What you can do is tell the patient to report that fake doctor to the police so that the police can actually make the investigation and can file the appropriate charges against these fake doctors.
I guess that's what
we don't need to be very proactive in the filing of the case against this fake doctor, because the police themselves can actually file the charges against these fake doctors.
Because it's a crime against
the state.
Yeah. Okay. Yes. Okay. I think you have another question here. Regarding the criminal liability for doctors, shouldn't this apply to all professionals constitutionally? I'm not very sure. Did you
constitutional? Well, if I would like to answer that question, it's kind of vague. But when you say professionals, I would like to believe that these are persons registered with the PRC, like medtechs, pharmacists, doctors, and the like. Now, all these professionals can incur criminal liability in relation to their practice of their specific profession. Let's say, for example, the architect or the engineer made this 10-story building and it collapsed because of negligence. Those professions can also be held criminally liable.
Okay. It's another question for you. Are Oriental medical doctors allowed to practice medicine in the Philippines? OMDs?
Oriental meaning to say they are not Filipino citizens.
Yes.
Yeah.
I think
As I mentioned a while ago, under our Medical Act of 1959, only Filipinos are allowed to practice medicine in our country, unless, of course, this foreigner can invoke reciprocity. In fact, even if this doctor will invoke reciprocity, he has still to comply with the requirements provided by the Medical Act, meaning to say he must take the board exams of the Philippines for the board to provide a board certificate of registration, or by way of endorsement, they are asking the board to provide medical services in our country, but for a specific case only. Other than that, any foreigner cannot be allowed to practice in our country.
Thank you. We don't have any more pending questions here, and I would like to thank the speakers. Thank you very much for such an engaging time, and we will surely long remember the messages delivered at this time. Can I just ask you for the last closing statements? Let's start with ladies first. Dr. Iris?
I had a plenary at the Philippine College of Physicians yesterday, and I had set 3 calls to action. First, for our specialty and for you as pediatric surgeons, to set the telemedicine competencies. Number 2, we need to actually look at implementation research because, you know, our setting is different. It's low resource. I've done the literature review. We don't have the capacity to do video consults all the time. So the third would be what will be our clinical practice guidelines. And I think the lawyers would sometimes say adhere to the standard practice, but what is the standard practice? So we need to write that down. Thank you.
Thank you. You just gave the officers of the Philippine Society of Pediatric Surgeons a job to do. That's going to be a big job for us. And Dr. Dominique, last words, please.
Sure. So first of all, I want to thank everybody again for the kind opportunity for having me here. I thoroughly enjoyed it and learned a lot as well. Just as a quick summary and a one-liner of my talk that I definitely want people to take home is to definitely recognize the power of different social media platforms, both for personal education as well as patient education and patient advocacy, but also definitely to recognize that there are caveats and there are limitations to these platforms, and we have to be mindful in how we put ourselves forward as professionals as well as scientists and educators as well towards our patients and towards the scientific community.
I like it that you remind us to be professionals on this topic as well. And it's close to your midnight there, and we thank you for joining us at this late time. And Attorney Abet, your last words, please.
Yes, again, thank you for inviting me in this webinar. And for the doctors out there, my only advice is that always make sure that everything is documented, whether face-to-face consultation or teleconsultation. Documentation is very, very important. It's the only evidence that we can have if a case is filed against us in court. Secondly, is always make sure there is consent. Never start treating a patient without the consent unless, of course, this is an emergency. And lastly, with the situation our country is facing, with the threat of litigation even before the pre-COVID pandemic, you always have to adhere to the standard of care. And with that standard of care, it depends on what specific specialization you are into. And for everyone out there, always stay safe.
Well, documentation, consent, standard of care. And I'd like to add another one, sir. You need to have an attorney friend. So let's be friends, Dr. Attorney Abet. So we are now coming to a close. Dear audience and participants, we'd like to thank you all for joining us. But please allow me now to introduce the one whose role that falls to, the Vice President of the Philippine Society of Pediatric Surgeons. That's Dr. Richard Pascual. Oh, I was just informed that it's 2:00 in the morning already with Dr. Dominique. So thank you. Well, Chuck, I have something more to say. Chuck has been active practice in Tarlac for about 25 years now. Yet he can be mistaken for one of his 3 sons. He looks very young, mostly owing to his pleasant personality and being an avid traveler and an active athlete. Colleagues, for our closing remarks, my good friend, Chuck Pascual. Signing off.
Thank you very much, Ate Dures. And good morning, everyone. The pandemic has changed the landscape for medical practitioners. That is a fact. But we cannot stop practicing what we trained for. It's an endeavor that knows no limits, even in these times of crisis. Today's webinar is very relevant to us clinicians who are facing challenges daily, because it is our responsibility to care, to cure, and if not, alleviate our patients' illnesses. But it's imperative that we do not compromise our safety in the performance of our concerns. The technology seeing patients in virtual history taking and somehow also physical examination is now the mode of medical or surgical consults. And however, this telemedicine and social media, as mentioned, is not free from any medico-legal implications, and it is one aspect of patient-doctor relationship that we must be wary of. I am extending our appreciation to our speakers today. Firstly, Dr. Dominique Vervoort, Dr. Iris Isip-Tan, and attorney and Dr. Albert Rebosa for a very informative and excellent lectures in telemedicine, social media, and its medico-legal implications. And of course, to our very youthful moderator, Ate Dures Tagayuna. I, being one of the technically challenged in the use of telehealth and social media, I learned a lot, and I hope our attendees may apply what we learned today. For the series of webinars in honor of our fallen comrade, Dr. June Resurrection, I commend the organizing committee for the very successful webinars. To the organizing committee, Dr. Bong Tuason, Dr. Edric Lin, and the other techie enthusiastic pediatric surgeons, Dr. Fawi Fausto.
Thank you for joining us this morning. All those who registered at our website will be receiving an email to the link for your certificate of attendance and CPD credits. You'll have to fill up the survey form in order to get your CPD credits. Thank you.